Let's everybody get seated and get started. We have several hundred people online, and we want to be respectful of wherever they are in the world. I guess we have these really bright lights because of the Zoom issues. Well, first of all, welcome. I think we have a really, really exciting program this morning, and I think you'll enjoy it. Second, I felt yesterday that it was quite remarkable how the session went really well and questions were unleashed. People were comfortable going to the microphone, and we would encourage, we hope that you'll be stimulated, you, our friends, will be stimulated once again to be comfortable asking questions at the end of these talks, because we have really, exceptional speakers with us, or investigators and leaders with us this morning. I want to make a housekeeping announcement, and I'll try and get it right. But it's an important one. Somebody inadvertently left a Lenovo laptop computer in an HPTN bag. I'll repeat. I know who did it. Call me. Well, I don't want to identify. It's a HIPAA violation. I don't know whose computer it is. I'm so used to it. I can't believe you violated it. Is it a HIPAA violation to say a computer's missing? I don't know. It's not, okay, I don't know anything about it. I just know that the person wants their computer back. If you pick up a bag and it's not empty, you see a bag lying there, let's all be like detectives, pick up a bag, if it's not empty, if it's heavy, look inside, don't call it bomb squad, look inside and bring it to the desk so the person gets their computer back, okay? So that's my one housekeeping announcement. Now, this morning we have, I really feel like a really special opportunity. Dr. Diefenbach, who everybody here is very, very familiar with, is here already, so you can start lobbying him and complaining even now, even as I'm sitting. He's over there. Feel free to wander to his table. There's a complaint box on his table. So but what we haven't, and he'll be speaking, he'll be with us, I hope, the next 2 days, and Dr. Jeannie Marazzo will be with us as well. But this morning we have someone you haven't really heard from before that's really important to us. We all have talked during the course of this meeting about the critical importance of sexually transmitted infections and other infections as they relate to HIV. And this morning we have Dr. Emily Belding, who is, and it's kind of wonderful because she came from a clinical background of running the STI clinic at Johns Hopkins in Baltimore. So she's got an in-the-trench experience that I think everybody can relate to. But now she's the director of the Division of Microbiology and Infectious Disease Immunology at NIAID. And she's going to tell us about the work going on within that group and about her aspirations and how we might collaborate. So we are collaborating already, but she might talk how we build on this. So thank you, Emily.
So thank you so much for the opportunity to come and present to you our priorities in STI research this morning. I hope that my thoughts can be motivating so that we can do more together in the future. So the topics I'm going to cover today, I'm going to talk first about vaccines for the bacterial STIs, gonorrhea, chlamydia, and syphilis. Most of our investments are in this area of prevention, and I think we have a lot of possibilities for successful vaccines in the near term. Near in science is maybe 5 years. I'm going to talk about alternative therapeutics for syphilis, some needs for new diagnostics, and then I'll just end on miscellaneous other things. So we're really, really happy that some of the sites in the HPTN were able to join the DMID trial, the trial that's testing the Glaxo vaccine designed for the meningococcus. This is a collaboration between NIAID, we're the sponsor, the Uniform Service University, Walter Reed, and GSK, the company that owns that commercially approved product. So this is a phase 2 study, which will test whether or not Bexsero, a vaccine with outer membrane proteins designed to protect against Neisseria meningitidis, also prevents anal genital gonorrhea. This is nearly fully enrolled, and it's endpoint driven, so there has to be at least a little over 200 evaluable endpoints, and we're hopeful that the results will become available within the next year. But thank you for joining this. I think will be a very productive collaboration. We do need gonorrhea vaccines, though, that are designed specifically to target gonorrhea and not gonorrhea's cousin. So there's a number of products that are in early stage preclinical development and late preclinical development, not in phase 1 clinical trials yet, that DMID is supporting. And I think I'll just actually step back and say most of the things that I'm going to focus on today are biomedical prevention, very product focused. So listed on this slide are some of the vaccine design concepts that are in preclinical development. Some of them have have looked promising enough that the US government funding effort called CARB-X, this is combating antimicrobial bacteria acceleration. This is a BARDA effort that NIAID has joined, and now there's multilateral partners from other countries joining with support as well. Some of these have looked promising enough that they've gotten a lot of support from CARB-X. And maybe one of the most exciting ones is Intravac, which is a company that's located in the Netherlands, and they have this intranasal, so a mucosal delivery, a vaccine that's delivered mucosally, and they've shown in animal models at least that there's cross-protective mucosal immunity in the vaginal epithelial with nasal inoculation. So that's very exciting, and we're hopeful that some of these concepts will enter into clinical testing within the next few years. GlaxoSmithKline, which is the product innovator for Bexsero, is also designing a outer membrane protein targeted vaccine that is very outer membrane vesicles from gonorrhea, designed and manufactured the same way that their Neisseria meningitidis vaccine is. So again, there's commercial interest in preventing gonorrhea due to the fact that it's an urgent threat for becoming untreatable, maybe with the current antibiotics that we have right now, untreatable in the next decade. So a vaccine would be a great advance. And so far, both observational data and data from animal models suggest that these design concepts could be very successful. Chlamydia is another bacterial STI that has been targeted, and there's some commercial interest in developing a chlamydia vaccine. I always try to meet with vaccine companies, big pharma, to try to figure out how their brains work and how they prioritize vaccines that they might try to make an investment in and move forward. And there's some companies, there's at least one company out there that thinks that this is potentially the next blockbuster, which makes me happy because I'd like to see the private sector do a lot of the work and move forward to successful advanced product development. But we also are investing in basic research and preclinical vaccine development. We have listed on this slide some of the projects and the investigators that we're supporting that are still in rather early stage preclinical development. I'll just note, though, that at the bottom bullet, the Statin Serum Institute has developed a vaccine that has already entered, a chlamydia trachomatis vaccine for urogenital chlamydia that's entered into a phase 1 trial. So that's promising. And then syphilis, which is an enormous problem worldwide. It's become very recently a huge problem in the United States with a lot of cases of congenital syphilis in the past year, and not very much interest at all, pretty much zero interest, I would say, from the commercial sector in developing a vaccine or really developing anything new, it would seem. And I'll just tell you that I don't know if Mike Cohen remembers this, but about 7 years ago when I was becoming director of DMID, he said, there's only one lab in all of the United States that is doing anything biological related to developing a syphilis vaccine. And she's going to retire soon, and that's horrible, and you need to do something about that. So Mike was a prophet, I guess, and we did just recognize that this is a serious problem, that it was a difficult bacteria to work with because at the time, at least 7 years ago, you couldn't cultivate it in the lab. There's no culture. The animal models there was one good one, the New Zealand rabbit, but kind of hard to work with, and the reagents that would be available for mouse work, for example, were not very available for the New Zealand rabbit. So we've made investments in this, and I think we're making progress, although certainly the pipeline is still relatively meager. So we had a workshop. Mike Cohen was there, being a cheerleader. We have a few more groups now that are applying modern tools, reverse vaccinology, structural biology, to Treponema pallidum to see what could be protective immunity. And shown on this slide are the results of one group's work where they've characterized the outer membrane proteins and identified ones that, at least with natural infection, seem to be important for protective immunity. So 2 groups now, that's 100% growth over the past 7 years since I've become DMID director, 100% growth in the labs that are committed to developing a syphilis vaccine. Tony Moody, who works with the Chavi group at Duke, is working hard on this and has identified the outer membrane, the OMB from the previous slide, is trying to move forward in developing that in testing it in animal models. And then Carolyn Cameron, a Canadian at University of Victoria, is working with a group in Seattle, has a different approach. This is good. 2 different shots on goal for hopefully a successful syphilis vaccine. And we're hopeful that with her approach, she's a little bit further ahead, may be able to move over 5 years, get into a phase 1 clinical trial. So a meager pipeline. We need more labs to come into this area, more international interest. But as far as I know, these are the 2 groups that are working on a syphilis vaccine. So I'm a little bit hopeful, but I'd really like to see more. But even if we did have a syphilis vaccine that was ready to move into clinical trials, you know, the diagnostics for syphilis are really, they have not advanced over the past 50 years, really. The only advancement in this would be, you know, there's the non-treponemal testing, which is a very non-specific reaction of measuring antibodies that react to cardiolecithin, you know, which is our cell walls, human cell walls. And then a specific treponemal test followed in sequence should the non-treponemal test be positive. And the only advance in the past 20 years, I think, is that there's now automated lab flow with an EIA-based test that can rule out syphilis in a blood sample. But if you happen to be positive, it made everything a whole lot more complicated for clinicians with this reverse sequence algorithm where you have to go back, if it's a reactive EIA test, and you have to go back and do the non-treponemal test follow in order to get a titer, in order to determine whether or not somebody has active disease versus whatever they had in the past. And it doesn't, there's no test of cure available currently. So I think that this is very painful and complicated for clinicians to apply to patient management. I think it also would make a really high quality clinical trial testing a syphilis vaccine with, you know, for clinical efficacy difficult because of the lack of specificity in our current diagnostics. So we're investing in new diagnostics for syphilis. It's hard to imagine that ultrasensitive PCR type tests or perhaps proteome or some sort of host transcriptomics that would show a reaction to Treponema pallidum being in your body. It's hard to imagine that those technologies couldn't be applied to this successfully and to give us better diagnostic testing. But even more of a crisis right now in syphilis in the United States and worldwide is the fact that we don't have access to therapy. So many of you know bicillin, benzathine penicillin G is the standard approach, either one shot if it's early stage syphilis or 3 sequential injections if it's latent syphilis. That's a standard approach, and there's no resistance that's been identified in this bacteria over time, and theoretically this is generically available and it should be inexpensive, but that just isn't the case. There's a worldwide shortage of benzathine penicillin. There's only one manufacturer. The bulk drug substance comes from China. There's all kinds of supply chain issues. And so we definitely need alternative therapeutics to be identified. So, and this isn't anything new. Over the past several decades, there have been many outages of various forms of penicillin G, benzathine, procaine, and aqueous. And so I think that other therapeutics such as linezolid, oral amoxicillin need to be tested in clinical trials. So coming out of the workshop that was on 2 slides prior that we had a couple months ago at Fisher's Lane, came a few new ideas that I hope will move forward into clinical trial concepts for clinical trials, and perhaps those would be things that the HPTN would be interested in doing along with DMID-funded clinical trial sites. Linezolid versus benzathine penicillin G for treatment of early syphilis is a trial that is currently enrolling in Spain and a few other European countries, and the results of that may be available by the end of calendar year 2025. There's currently a trial ongoing of cefixime for early syphilis in women. People are hoping, these are non-pregnant women, but people are hoping that that could be a effective therapy for maternal syphilis if it's shown to be effective in this ongoing trial. I know that you've heard about our doxycycline versus penicillin for treatment of neurosyphilis and ocular syphilis. Thanks to Ken Mayer for stepping in and helping us develop that protocol. Hopefully that's something that we can do together. And then there's other concepts under discussion that I think could be very fruitful for collaboration between DMID and the HPTN. Amoxicillin, along with probenecid for early stage syphilis, perhaps a trial that would test whether you need 1 dose of benzathine penicillin G, save the last 2 injections if it's high titer syphilis of unknown duration. And there's probably lots more that could be added to this list. So I just wanted to talk about new diagnostics that are also being developed through collaborations with one of our sister institutes at NIH, NABIB. They were very active in developing point-of-care tests and home-based testing for SARS-CoV-2 during the pandemic, and they are working on a multiplex test for direct detection of agents that cause general ulcer disease. So Mpox, very important right now, and as well as herpes and treponema pallidum and varicella zoster. So we're hopeful that within the next year, testing for that can be introduced into clinical trials, and maybe that will be something that sites in the HPTN can participate in as well. And then this is the miscellaneous slide, just other efforts that we would be happy to talk to you about, collaborations that could be built too. We are working on a vaccine for hepatitis C. Treatment for hepatitis C is excellent, but people tend to get reinfected. And I think that a preventative vaccine for a disease that's associated with stigmatizing behavior and people who are not really linked to healthcare systems very well, I think in order to eliminate and maybe even eradicate hepatitis C, we probably do need a prophylactic vaccine. And a trial for that will probably, once those vaccines are ready for testing, a trial in that area might be very difficult to do. We're certainly interested in both therapeutic and preventative vaccines for herpes. I'll just mention that a lot of companies are interested in that as well, so there is commercial interest. Moderna has a therapeutic vaccine trial that, as I understand, is fully recruited. BioNTech has developed a herpes vaccine. So we're interested in being helpful in those companies' efforts moving forward. But we have to make investments in things that the private sector is not willing to invest in. And then I think herpes monoclonal antibodies, which might be very useful in preventing maternal-to-child transmission, we're also supporting groups that are working on that. That they might also be useful in serodiscordant partnerships in preventing sexual transmission to the uninfected partner. So that's an area that might be fruitful for future collaborations as well. And this is my last slide. I think the other thing just to mention in this whole area of bacterial STIs is community and the need to build community awareness in order to make successful progress in some of these important areas. This is a I think it's a new public awareness campaign that the AIDS Healthcare Foundation, mostly in California, has developed, but it's also on the sides of a whole lot of MTA buses in Baltimore City. And just in the past few weeks, this has been launched. Apparently, people that are getting syphilis or perhaps are at risk for syphilis, which is a lot of people lately, have no idea what the health consequences of syphilis can be in terms of ocular complications, in terms of pregnancy outcomes. Stillborn births is one of the things that have been recorded in record numbers in the United States in the past few years. So I'm told that with just this campaign on the side of buses in Baltimore, a lot of patients are coming in to just their primary care providers and asking about syphilis and whether or not they can get a syphilis test. That's a good thing, but we probably need to do more of that community engagement and building community awareness in order to be successful in developing these preventative tools and testing them in the future. So, thank you, and that is my last slide.
Well, that was a wonderful tour de force. Remember, Emily has a lot of pathogens. It's not, this is only a small part of her portfolio, so that was really a tour de force and wonderful. And we're going to hold questions till after our next speaker. And I think what's interesting is, remember the Prevention Trials Network, we're a research network developing tools in many different spaces. But if we develop those tools and they're never deployed, that's a really, really bad idea. And so our critical partner is the Centers for Disease Control and Prevention. And we're really pleased today to have Captain, and you'll notice she's a captain because of her uniform, that can't go hidden, Captain and Physician Robin Nesbitt Fanfare with us from, who directs Division of Prevention in the Center for HIV, STDs, and Tuberculosis. And so Dr. Fanfare has had a very distinguished career at the CDC, and from my point of view has been particularly involved in treatment as prevention vis-a-vis the pillars of the end of HIV epidemic in the United States. So I would think her being with us is really critical, and we hope we're developing tools that you want to use, Robin. So thank you so much for being with us.
Well, good morning, everyone. Thank you so much for having me. I must admit I was a little nervous watching Emily's talk, like, now why am I here? But it was so wonderful. Thank you for that introduction, Mike, to show the connection. And also when she ended, I thought that that was so powerful. And I'll just say, those are also on bus stops in Miami. I was there recently for a family wedding and stopped to take a picture and had a very interesting conversation with my 12-year-old about why I was taking those pictures, and talked to her about a little bit about the work that I did at CDC on ocular syphilis before coming to DHP. And just another full circle moment, Emily, or as I used to call her, Dr. Belding, offered me my first job after fellowship as medical director at the Druid STD clinic in Baltimore City. So a real full circle moment for me today. Thank you again to the HPTN organizers for having me. It's a pleasure to be here to represent CDC and talk to you a little bit about the work that we do. So I always want to start with the impact of so many things before I ever talk and set the framework of the disparities that we're seeing. So we all know that we've made tremendous progress since the start and the early days of HIV, fueled by landmark advances in HIV prevention and treatment that so many people in this room played a role in, as well as the hard-fought battles by activists, advocates, and community. Longstanding barriers to prevention and care continue to mean that everyone is not equitably receiving access to these interventions. Addressing these barriers and the social forces that drive them is a priority for CDC. Our goal is equitable access to HIV prevention and treatment resources for all. Now, we often talk about the progress we've made as a country, but large inequities exist. And as the next slide will show, Black and Hispanic, Latino, gay, bisexual, and other same-gender-loving men, women of trans experience, and cisgender Black women continue to experience disproportionately higher rates of HIV. This is because of the impact of racism, homophobia, transphobia, discrimination, and stigma, all significantly exacerbate the health disparities experienced within the communities we come from and we serve. So it's estimated that 1.2 million people in the US were living with diagnosed and undiagnosed HIV at the end of 2022. Here's a snapshot of the key disparities across the range of HIV-related measures and outcomes that CDC tracks. These trends help guide where CDC and our grantees direct our resources, our programs, and our interventions. HIV incidence continues to be higher among gay and bisexual men, Black people, and Hispanic Latino people. The biggest gaps in PrEP coverage continue to be among communities that disproportionately could benefit from PrEP. More HIV outbreaks occur among people who inject drugs than other groups. The Southern United States continues to have the highest rates of HIV diagnoses than other regions. And when it comes to HIV care, among people who receive a diagnosis of HIV during 2022, Black people and women had the lowest percentages linked to care within 1 month, and similarly had the lowest percentages of viral suppression. There remains much work to do. Let's talk a little bit about our approach to the Ending the HIV Epidemic initiative and some of the results we've seen thus far. So CDC has partnered with our cousin agencies in the EHE initiative, and there are 4 main pillars within this initiative: diagnose, treat, prevent, and respond. In this slide, it highlights some of the critical data points that set the stage for why domestic HIV prevention continues to be so critical. In 2022, there were 31,800 new HIV infections, with a lifetime medical cost of a little bit over $500,000 to treat a person with HIV. The medical care cost for people who got HIV in 2022 alone is $15 billion over their lifetime. CDC puts a significant amount of funding out to health departments, community-based organizations, and to build workforce capacity. In our most recent surveillance report that was published in May of this year, we found a significant decrease in HIV incidence in 2022 compared to 2017 across EHE counties, where HIV incidence declined by 21%. Congressional appropriations for EHE across the last 2 presidents have made a big difference and had a huge impact. Now let's go pillar by pillar. In the diagnose pillar, between 2021 to 2023, using EHE funding, health departments conducted more than 830,000 HIV tests, for which 3,000 people received a new diagnosis of HIV. Let's talk about self-tests. In 2021, we distributed 100,000 free-to-consumer HIV self-test kits to disproportionately impacted communities, and more than 500,000 tests were delivered in 2023 and through 2024 thus far. We love to give context to the numbers, so let's talk a little bit about what's going on at the local level. So EHE in action for diagnose. In Louisiana, East Baton Rouge Parish, the rate of people living with HIV is 3 times higher than the national average. Fortunately, leaders from across the parish were able to use EHE money to collaborate and put programs in place to aim to end the HIV epidemic in the community. One of these programs used a holistic approach where community health workers, including nurses, provided a range of health and prevention services in the community where they're needed. These services, which may not be directly related to HIV, include distributing condoms and PrEP information, screening for HIV, hepatitis C, and syphilis, and helping with food assistance. This example reflects a priority of CDC, to reach people where they are, where they want to be met, and with what they need. For Prevent, EHE funding we sent to health departments resulted in innovative prevention work, including more than 55,000 people being prescribed PrEP. And between 2021 and 2022, we also funded over 260 syringe service programs, of which more than half were mobile. Now, with support from EHE going locally right into Cobb County, T.O. Vincent Health Center launched a new PrEP program. This program expanded the reach of the healthcare system by enabling registered nurses to connect more people to DeKalb County and vital HIV prevention options. EHE resources were used to train nurses so that now, during patient discussions, nurses can now offer PrEP to patients. And for the treat pillar, in 2021, CDC grantees used funding to link 84% of persons newly diagnosed with HIV to medical care within 30 days. This includes innovative practices such as rapid ART, telehealth, and employing peer navigators. Our final example of EHE in action is in a rural community. During COVID-19, HIV clinics and people seeking HIV-related services had to adapt to a new reality. Telehealth became a crucial and transformative way for some HIV clinics to provide a lifeline to patients. Telehealth can be accomplished via phone, tablet, computer, and in rural Kentucky, 2 organizations created successful telehealth models using EHE funding. These organizations show how forward-thinking strategies can strengthen health systems, build meaningful connections with people with HIV, and help save lives. This is just a summary slide of some of what we've discussed, the impact and results of the EHE initiative from CDC-funded programs over the last few years. Let's end talking a little bit about CDC's 2024 priorities. So over the next year, we'd really like to augment and elevate our current efforts with 3 priority areas that will help us reach all people who could benefit from HIV care. Each of the priorities I'm going to talk about is intended to advance health equity among all people. And I want to be explicit. When I'm talking about the work we do to advance equity for our youth, our Black and Indigenous and Brown communities, people of trans experience, rural communities as we've discussed, same-gender loving men in the South, equity has to be the heart and foundation of all of our efforts. I want to emphasize heart here because in order for us to reach our goals, we must think beyond just the data and lead with our hearts. You'll see this in the theme of our priorities. I call these priorities the 3 C's: care, connection, and community. Improving care, raising the quality of life for people with HIV, including linking and relinking people to care and encouraging sustained viral suppression. Connecting people to PrEP, increasing PrEP adherence, uptake, and retention, especially in communities where prescriptions are low. And engaging communities, creating and sustaining new partnerships, and ensuring people with lived experiences are heard. Let's dive a little deeper into each priority. I want to highlight some examples of CDC work to improve HIV care that I'm particularly proud of and hope to build on in the future. First is our Let's Stop HIV Together campaign. This is a campaign that empowers communities, partners, healthcare providers to reduce HIV stigma and promote HIV testing, prevention, and treatment. Let's Stop HIV Together consists of print materials, social media toolkits, digital resources, and more. These resources include English and Spanish, and we've also provided technical assistance. Also here, let's go a little deeper into the Together Take Me Home program. This program aimed to distribute 1 million free HIV self-test kits over 5 years. And in the first year, just a little over the first year, we've already distributed 500,000 tests. It shows incredible demand in the community. Together Take Me Home is a 5-year partnership with partners including Emory, Building Healthy Online Communities, NASDAD, Signal, and OraSure. HIV testing is a critical tool to re-engage people in care. Data shows many HIV tests can come from people who were previously diagnosed and then no longer in care. Each test is another chance to help someone get back into care and remain healthy. We're proud to report that as of April 15th, over 500,000 tests have been distributed, and we're well on pace to reach 1 million tests well before. Together Take Me Home can be accessed at the website at togethertakemehome.org. Let's move to connection and care. I'd like to highlight 2 recent social marketing campaigns. So often in community, we still hear from people, I didn't know that PrEP was for me. I didn't see myself in the marketing. #She'sWell is focused on increasing awareness about PrEP among women, building capacity among clinicians to prescribe PrEP to women, and ultimately increasing PrEP use among women. Prepared, or Preparado, is a culturally tailored, evidence-based social marketing campaign that aims to increase PrEP prescriptions among Black and Hispanic and Latino gay and bisexual men in the South to increase PrEP awareness among care providers. In implementation science, we have several projects, including PrEP Choice. PrEP Choice is an implementation research study to increase PrEP use among Black and Hispanic, gay and bisexual men at 11 health clinics throughout the nation. The ongoing study assesses participants' preferences related to education and support, in addition to different forms of PrEP, including daily, intermittent, or long-term injectable versions. And Transcend. Transcend is a demonstration project that connects people of trans experience to HIV prevention and treatment. Transcend works by funding transgender health clinics to work in collaboration with transgender-serving community-based organizations. Ultimately, it aims to develop successful models for community-to-clinic, whole-person HIV prevention and care services for people of trans experience. And finally, community in action. To end health disparities and inequities and achieve national HIV goals, we must reach people in communities disproportionately affected by HIV. To know how to do this well, we must continue to listen to community and the people we serve through bidirectional community engagement. Most recently, we completed 6 Southeastern community engagement sessions in partnership with NACCHO, the Southern AIDS Coalition, and regional community conveners. The aim of these sessions was to discuss barriers and opportunities to promote health equity, expand community engagement, understand local program around syndemic and whole person approaches. We just completed this round of sessions in May after visits to Atlanta, Jackson, Houston, Memphis, Miami, and Baton Rouge. Trends and messages from these sessions include so much more about the workforce, how we need to bring in the next generation of community leaders, the importance of quality of life, not just for the people that they serve, but often people who are working in community face issues with quality of life as well. Some HIV caseworkers themselves shared how they were currently couch surfing. And when the funding pie for community-based organizations is small, organizations with shared missions are forced to compete with one another. We learned more about local and community environments. What are some of the barriers and obstacles to PrEP, PEP, HIV testing and care? And of course, how can we help support the relationships between community-based organizations and health departments? Now that these sessions are finished, it's critical for us to synthesize all that we've learned and feed it back to community. There'll be 2 sessions this summer, one this month and one in August, where we'll be joined with community members and health departments to feed back the information that we learned from these community sessions and talk about what the next steps are for us at CDC. Finally, I just want to touch the foundation of our work. Once again, has to be equity. Health equity is the state in which everyone has a fair and just opportunity to attain their highest health. While we think about the 3 C's, we have to think about how to overcome barriers to health equity. We can improve HIV care by doubling down on increasing access for all and re-engaging people not in care. We can ensure connection to PrEP by closing awareness and access gaps, and we can expand community engagement by reaching and listening to new and non-traditional partners. Our ability to end the HIV epidemic hinges on addressing HIV inequities. This work, stopping new infections, expanding equitable access to prevention and treatment, and improving the quality of life for people with HIV is what will make ending the HIV epidemic in the United States one day possible. Thank you.
Thank you, Robin. That was kind of exactly what we needed to hear. So we have about 15 minutes for questions. And so if we can turn the light, yeah, thank God. Okay, so we have several questions. I guess Wafa can start. Wafa, you got the first question.
I'm not sure I know how to turn this on, but there must be a button here. It is on. Oh, thank you. Okay, thank you very much, Emily and Robin. Very interesting talks and complementary in many ways. I think on a lot of people's minds in this room are the issue and the potential of course, another outbreak of Mpox this summer in particular. And I'm just wondering in terms of, and there's also concern about the new clade that's been identified in DRC that appears to cause most severe illness. So from your different perspectives, what do you think we should be focusing on now in terms of trying to answer research questions, but also trying to ensure there's sufficient access to vaccines and treatment and diagnostic tests in this country and around the world? Thanks.
Well, I'll start. Can everyone? Yes, you can hear me. I want to say thank you for the question. It continues to be a huge priority, not just, of course, at CDC, but really across HHS. And so when we think about Admiral Levine has really continued to make it a priority, and the Secretary, Becerra, for HHS, thinking about Summer of Pride. Very similar to what we're seeing with PrEP, right, is that awareness. Are people aware about the Mpox vaccine? Similarly, we've seen continuing disparities, continuing racial and ethnic disparities, where so many people who could benefit from the vaccine have not been able to access or have not accessed the vaccine. So in this Summer of Pride, really making sure that people have that awareness and access to the vaccine is really critical. And that's a lot of work that's been going on across the agencies. And then also just making sure that there is a bidirectional communication and really a strike force that's keeping a very close eye on what's happening abroad as well as here to ensure that should any of that occur, there's a strike force across the federal agency who's ready to support.
Yeah, I think all of that, but also I think we need to finish the STOMP trial, which is supported by NIAID, and will show whether or not and under what conditions the tecovirimat or TPOXX is an effective therapeutic. And then there's also an ongoing trial in DRC enrolling hospitalized children in DRC where the Mpox has been endemic for years. At DMID, we're trying to go forward with getting the Jynneos vaccine licensed for adolescents. It isn't licensed for adolescents, and we want that to be both FDA approved and EMA approved, hopefully within the next year. So those are our research investments. I mentioned that we're also trying to work with NABIB to develop a diagnostic test that might be point of care. That one is probably really, really important because early detection and discriminating what your ulcerative lesion is due to will also enable people to get the right therapy and to minimize transmission to others.
Emily, any ideas about when the STOP trial will be? I mean, I hate to get under the hood, but there must be a DSMB, and you must have some sense of does this stuff work or doesn't it work? You can tell us now.
Yeah, I guess I'm going to pass that off to Carl Diefenbach because really it's not,
Carl
it's the ACTG repurposed for Mpox. That's
all right. Well, you brought it up, but now we put him. Does this stuff work?
Trial's continuing. The DSMB says, what they always say, we really like your preliminary data. Data is of quality. Keep going.
All right, thanks for the update. Ken, Dr. Ken Mayer.
Really excellent and very stimulating talks. The one term of art I didn't hear mentioned this morning was doxycycline post-exposure prophylaxis. So I'm curious, Dr. Belding, about thinking about what are the opportunities for synergies between a network like HPTN that's enrolling lots of people at substantial risk for HIV. There's one protocol, HPTN 113, that has embedded evaluation of doxy-PEP, but there certainly are other potential opportunities. And I'm curious for Dr. Nesbitt, thinking about how the CDC branches are interacting about messaging around this and further implementation science work to see the long-term impact of the innovation.
Thanks, Ken. Emily or Robin first?
Yeah, there actually are a few investigator-initiated clinical trials that are, and other types of studies that we're supporting. It's disappointing to not know how well this will protect women. And so I think it's really important for somebody to study that and get answers for cisgendered women who may be at risk for bacterial STIs. I know that you can ask Connie Kellum what she wants to do. So again, it's not a network thing, it's an investigator-initiated thing as the original doxy-PEP trial was, but there are plans to roll this out into a large number of US cities and to test things like antimicrobial resistance over time. So that's what we're planning on supporting.
Robin?
I'll just say, completely agree. And DoxyPEP, there's been a lot of conversation within the centers. The center has not just my division, DHP, but also the Division of STD Prevention, among others. And so there's been a lot of conversation about how this really can serve as a blueprint when we talk about syndemics, when we talk about syndemic models. So just last week, the two divisions were able to come together very soon, clearly after the guidelines came out, and talk a little bit about what those synergies can look like, whether it's an implementation science, demonstration projects. And then we'll also be following up with NIH. We have a quarterly conversation with NIH, and the next one this month in June is going to be specifically around DoxyPEP, bringing in both colleagues from the Division of HIV Prevention and STD Prevention. So it's definitely a high priority for us at the center.
Thanks, Rob. Is Sybil, are you here? Do you want to just, I think it's a good opportunity for you to mention the ATN, our sister, because remember, we're partners with many networks, and the Adolescent Treatment Network we're partners with as well, managed by an ICHD. Sybil Hosig is the principal investigator of the one of the principal investigators. Sybil, do you just want to really quickly say what your trial is?
Sure. Our trial is focused on adolescents, ages 15 to 24, although we're probably writing the protocol to go up to 29 to be more inclusive. Cisgender women and others assigned female at birth, looking at 3 different arms of DoxyPEP. One is the coitally dependent or on-demand, one is a weekly dosing, and then one is standard of care. So we are hoping to launch in the fall, and are also hoping for collaboration across the networks.
Thanks, Sybil. Yeah, so I think I think it's really, the CDC launched wonderful guidelines just last week from you, but it's focused on men, and this idea that women get left behind is I think, an issue that we're all really concerned about. So our network really will try and be involved in this, if at all possible. Thanks. Yes, identify yourself,
Yes,
as I can.
Rogers from Beira, Uganda. My question goes to Rob from CDC. Yeah, you indicated that there are about 1.2 million cases, and you have about 1 million test kits to distribute within 5 years. However, we are interested in knowing what is the yield from the initial distribution. Thank you.
I'm sorry, when you say yield,
The yield,
do you mean percent positivity?
correct.
Yeah. So with HIV self-test kits, if you think about it, it's something that we're sending to people in their homes who can either use it themselves or give it to partners or other friends or family. And so it's really not a test kit in the way that you would go into a clinic, let's say, and be able to kind of get that result back. So they do get that result. We do offer them to provide information back to CDC, but that's by self-report. And so offhand, I want to say maybe about half of the people who receive the kits actually do respond to the survey. I don't have the percentage of positivity offhand, but I do think that in general, what we're seeing with this demand, and as I said, 500,000 in the year, and I don't want people to think like, oh, we're just going to get to the 1 million and stop. I think we're really thinking about ways to increase the funding that goes so that we can help meet the demand. I think more than just the positivity, it also serves as a gateway, right? A gateway to have conversations around HIV prevention, around access to PrEP, around access to DoxyPEP, conversations about PEP. And so really seeing this demand shows us how important kind of breaking down those traditional models are to really be able to meet people where they are. Thank you.
Thank you. Yeah, I thought I saw, there may be something I'm missing because I can't see very well, but I think you're next. I hope you're next. And if there's somebody on a microscope, my microphone I haven't seen. Oh, I'm sorry. So I think can you see? Can you see? Okay. The lights are so bright. So I think the next were the
Why
three
don't we
people.
take the front microphone,
Sure.
please?
Hi, Leo Fitz, 096 Social Media Manager. This question is for Dr. Fanfare. I love that you touched on campaigns that specifically addressed those marginalized communities and your focused demographics. Can you kind of expound more on the role that social media and digital advertisement play in addressing the HIV epidemic?
Thank you. I think, it really goes in line with kind of the answer to the last question when I say meeting people where they are, right? I think there's so many lessons that we learned from COVID-19, right? I'm also, in addition to this role, also serve as a primary care provider. And we saw within days to weeks having to go from seeing people in the clinic to being able to offer telehealth services. Now, 4+ years later, I still have veterans that that's the way that they prefer medicine. And we wouldn't know that if we weren't kind of forced to break down these non-traditional models. So I think social marketing is another space. I'm of a certain age, but I do have social marketing. I do have social media. But in this job, my younger more savvy staff taught me how to do my first Insta Live. And I can only imagine the people that we were able to reach in that way that we're not able to reach in our more traditional Let's Stop HIV Together campaign or things that we're putting up in certain clinics. But we are able to meet them where they're already seeking, not even care, but just their entertainment, where they're engaging. And so I think it's extraordinarily important when we think about our adolescents, our youths, populations that are disproportionately impacted, that we're just a little bit more creative and innovative to not make them come to us, but make sure that the messaging is helping to reach them where they would like to receive that information.
Thank you.
Thank you, Rob. Yeah, the second mic.
The back, yeah.
Can you see better? Okay.
In the back there.
The back, yeah, and then the
Yeah.
next. Okay.
Hello, I have a question about the Take Me Home program. I was wondering how community organizations are helping people how to use the tool, because some people might not know how to access the website and order the self-testing. So I was wondering if there are any organizations that are helping people on how to order the test.
Absolutely. So part of the slide that I didn't necessarily present is that through CDC Foundation, we also have some work that's going on specifically in community-based organizations where they've been able to help distribute 51,000 HIV self-test kits and do the support that's needed. I'll actually say it's fairly simple. Kind of going back to the last question, for one of our awareness days, I was able to do with Queen, a wonderful woman of trans experience. We both did the self-test kits on Instagram Live together to try to show people how easy it is, went step by step from opening up the package to actually, of course, getting the results. And so I think that there are all of these different ways, whether it's community-based organizations, Instagram Lives, physicians, to be able to show individuals how you can actually use it is really important.
Yes, please.
Good morning, Marvell Terry II. I'm a member of the HPTN 096 Community Advisory Group. My question is to Dr. Fanfare. Good morning. I know that your priorities consisted of engaging communities, connecting people, and improving care, and we cannot do this as we recognize Juneteenth this week, acknowledging that our Black-led organizations are closing. That our institutions in our communities do not have the infrastructure to funnel much of what you're doing through. And so in your office, is this a priority to ensure that Black-led organizations are staying open?
Marvell, we've been having a lot of these conversations internally very recently. So I will say that it's a priority not just to myself, but to the division as we think about capacity building in the organizations that we support, that this can be a priority or will be a priority. So thank you for mentioning that. It's extraordinarily important.
Thank you, Robin. Yes, ma'am.
Good morning. My question is to Robin. I'm Dr. Ade Kechitinwa from Bela, Uganda. And at Bela, Uganda, we rolled out telehealth services. And I would love you to share more lessons on telehealth services. For example, we find that people call in more for PrEP, and the younger people are more males. So what experience could you share regarding prevention versus care versus retention for telehealth services?
I don't have any specifics to mention, as you're saying, but I think what we have seen from the projects that we support, whether it's through health departments, whether it's through community-based organizations, as I said, for myself as a provider, it's really another tool in the toolbox. When we think about ways to meet people where they want to be met, we've seen that telehealth, even now, 4+ years into COVID-19, for me, it's just the way that some people prefer to receive care. It's been remarkable, and so many of them continue to have viral suppression. So I think for me, it's really just seeing it as another option. If we talk about self-tests that go to people's homes, if we talk about telehealth and that's the way they want to access care or treatment, it's all of us thinking about newer, sustainable, non-traditional, innovative ways so that people are able to seek HIV testing, prevention, and care the way that they'd like.
Thank you.
Jessica? I think that's
Great, thank you so much. Dr. Fanfare, I was really struck by the example you showed about opt-out HIV testing in the Baton Rouge Emergency Department. And it made me remember during my residency training quite some time ago, at that point in New York State, it was required that all inpatients being admitted had to have a syphilis test as part of the admission set of orders. It wasn't even presented as an opt-out, but which you could criticize that, but it was just absolutely standard. And that went away. And I wonder, maybe from the data you're seeing in Baton Rouge, you know, what's the yield? I understand the yield will differ in different parts of the country, but you know, maybe there are some discussions going on or thoughts about going back to these required inpatient testing for syphilis, for HIV. So it almost becomes a structural intervention when you just make it part of the package. And I'm just curious if that's something that you've already been talking about or discussing.
It absolutely is something that we've been talking about and discussing, really focused around HIV, not necessarily syphilis, but as we've gone into certain communities, as I said, in the Southeast, we've been talking to them about the hospital settings, right? And not just the emergency room, but that inpatient space where you have people for days or sometimes even longer. That's definitely an opportunity for HIV testing and what can be structural in that space so that it's something that the provider doesn't even have to think about. So those are conversations that we've been having internally, as well as when we go into community and thinking about ways, because that will need their state and local support as well. So we've been having those conversations in both of those venues. Thank you.
Okay, we're running out of time, so brief questions. Yes, sir.
No problem. Thank you so much. My question is to Dr. Robin. So in terms of strategies that you used to engage either people in remote communities and or people who have no access to mainstream media and or social media, what strategies did you use and how effective were those? Thank you.
Thank you. I think there's one that I'd love to highlight is really thinking about, because it is a gap as we think about how are we able to access, I'll use the word rural communities here domestically. So one project that we have that's going to be starting that we're really excited about is using community health workers. So using community health workers who are in the space who can go to the homes and help support with HIV prevention, treatment, testing in the home. That's one thing that we're looking at. So community health workers going out into rural spaces. We said telehealth is fantastic, but we do understand that there is a digital divide for some communities. So finding ways to break through those barriers is something that's also a priority. And that's one project that'll be starting soon.
Thank you, Robin. Yes.
Yes, Laramie Smith, UC San Diego, 094. Just briefly, this is more of a comment. I wanted to thank you for bringing this particular panel together, because in listening to the ways that we might be able to partner with new vaccines and new trials, and then listening to Dr. Fanfare's conversations, it also made me think about across our protocols, what more we could be doing to build into them, how we can learn where to deliver those treatments, you know, to our communities, where they're at, how they want to access them, and how we can also start to consider stigma reduction as part of integrated strategies into our protocols, so that the lessons that we're learning are being put forth into our communities and potentially optimizing their impact.
Thank you. Next question, please.
Robert Klitzman from Columbia, also for Dr. Fanfare. Thank you. I was wondering, you mentioned that there are discussions going on following Jessica Justman's question about whether to mandate testing for HIV or syphilis. I'm wondering if you can elaborate what the pros and cons are seen as being.
Well, I'll just speak broadly for a community where we were. They weren't sure if there was going to be, when we had that conversation, if there was going to be the political support, and were they able to kind of have the legal support to be able to have that conversation with the local hospital. So I think for us, we see a lot of pros, and as I said, internally, we're thinking about the levers that we can pull. Clearly, we're CDC and a federal agency, and so there's certain things that we have at our disposal and certain things that really do have to be at that state and local. And in that space, they weren't sure if they would have the political and legal support to be able to start that at a local hospital. So those are one of the cons that came to us in a community engagement session.
It seems that guidelines from professional organizations could help push that forward.
Okay, thank you.
Thank you.
I want to blindside Emily. Emily, so I'm going to blindside you. Let me ask a question. How many in this room were involved in our COVID activities 4 years ago, COVID clinical trials? Just raise your hand. And the site investigators, most are, okay. So what I just need to, most of you will be getting an email very soon about our concern about something that Emily is very concerned about, and that is H5N1 influenza. The networks have decided that they're going to reinvigorate the calls we had on Monday with all the site investigators. Maybe 1,000 people were on these calls on Mondays, and they're going to explore the history and where H5N1 influenza is going. Unfortunately or fortunately for us, Emily's also in charge of that. So, so can you just say a word about your division's H5N1 activities? And I want to forewarn the people in the room that these calls will be open, and this is the pluripotential nature of the networks. They're an army. They're an army of very talented people that need to be available. Carl, shake your head yes, because you made us COVIDologists. This wasn't our idea to be COVIDologists, and so we are going to be prepared. So, Emily, blindsided.
Yeah, so I think everyone in the U.S. and probably outside the U.S. has heard about high-path avian influenza H5N1 that has been circulating in the birds, wild birds, has spilled over into domestic poultry and killed a lot of birds, and is now in dairy cattle, which is a really surprising animal to be infected by H5N1. And there have been a few cases of farm workers who have been exposed to dairy cattle and have gotten relatively mild disease in the U.S. Tackling the whole issue is a problem because it's stigmatizing for dairy farmers to have cattle that are impacted. A lot of the people that work on farms and farmers apparently don't trust the government, and health departments have not been invited onto the farms to test. So we don't really have a good handle on what is really going on with this outbreak in the United States. I think some people simply wish it would just burn out and go away, but we're not optimistic that that would happen. We know that there's certain mammalian adaptations genetically that have been described in some of the cattle strains. We're very worried that human-to-human transmission could become something that becomes more efficient if there's mammalian adaptation over time. And we would need a big population-level vaccination effort to protect us, the world, if human-to-human transmission happens. So that's dark. That's a threat. We have a number of people that are funded by NIAID working on more broadly and durably protective vaccines, but they're not even into clinical testing with some of those promising candidates yet. And the U.S. government is stockpiling more traditionally manufactured H5N1 vaccines that match the current strain. A limited number of doses, and that could be scaled up. So that's the state of the art. But yes, it's possible that we're facing another pandemic, and a very large-scale vaccine trial effort might need to be launched.
And therapeutics? Do you have any new therapeutics?
The cases, the human cases so far, the isolates has been susceptible to the traditionally available therapeutics, all classes.
Okay, so this was a wonderful session. Let's thank our speakers.